going to talk about colon cancer. I think all of us are aware that patients with inflammatory bowel disease are at increased risk of developing colon cancer. And there are many factors that come into play in terms of the personal risk for any particular patients. The duration of the disease, so a disease of more than 7 to 8 years, the extent of the colonic involvement. So typically if you have more than one segment, 1/3 of the colon being involved, these are your patient at risk. A family history of colon cancer or personal history of colon polyp. Of course, if they have primary sclerosing cholangitis, PSC, these patients are at high risk of colon cancer. Their lifetime risk is around 30% of developing colon cancer. So these are the patients you are going to screen on an annual basis. But also now we're recognizing that the burden of inflammation is important. How long the inflammation has been going on before we're able to control it. We all have some patients that have a low level of chronic inflammation in their bowel. These patients are at high risk of colon cancer. I like to explain to the patient that it's like somebody having multiple sunburn has an increased risk of skin cancer.
On the inside, yes.
Right, on the inside, exactly. So it's important to put all these factors into play into terms of how you're going to personalize colon cancer screening in patients with IBD. Why do patients with IBD have an increased risk of colon cancer? It's probably multifactorial, whether there's genetic instability because of the nature of the disease, immune response, there's an oxidative stress that's involved in the inflammation, and also probably some degree of microbiome dysbiosis. So, but however, the good news is we must be doing something good and a good job. The risk of colon cancer in patients with inflammatory bowel disease has been decreasing in recent years, probably due to two main factors. One is we have effective therapies controlling the inflammation, and so our risk of developing colon cancer will decrease, but also because in most places, most physicians seeing patients with IBD have implemented a colon cancer surveillance program. We are not letting these patients go without a good surveillance program. So what are the guidelines in terms of colon cancer screening? If you have Crohn's disease and a disease duration of more than 8 years and more than 1/3 of the colon being involved with the active inflammation at baseline or during the course of the disease, then you start colon cancer screening every 1 to 3 years. If you have a patient with ulcerative colitis and PSC, these are your patients where you start screening at the time of diagnosis once a year. This is really where there's no much room to play because, again, these are patients at very high risk of developing colon cancer. In patients with UC without PSC, if they have disease limited to the rectum, proctitis, these patients overall are at the similar risk as the general population, and probably you can get away with screening every 5 to 10 years. But if they have disease involving more than the rectum, of 8 years duration, you put them again on a program of 1 to 3 years. And the reason we have a range of screening every 1 to 3 years is because you want to put together all those risk factors that you have. If you have a patient who has been in endoscopic remission, since diagnosis on effective therapy, no family history, never had a polyp, you probably can do a colonoscopy every 3 years. But if you have a patient with more risk factor, extensive disease inflammation that was difficult to control, a family history, I would put that patient on a yearly program until that patient proves to me that now they are at lower risk over time. So personalize your screening interval to the patient risk factors.
It's interesting that different parts of the world actually have different standards, and if you go to the UK, they have much more flexibility and longer intervals based on what the prior procedure showed and what the pathology showed.
I agree.
And other factors.
I think in the UK, they even have an interval of every 5 years for the low risk,
that's right?
I think the most I've been spreading the colonoscopies every 3 years.
Yeah.
I'm not
5 would not be the standard of care in this country.
So in this country, every 1 to 3 years is appropriate. And also you want to ensure that the quality of a prep was good, the quality of the surveillance was good. So all these are also factors, right, that takes into account when is the next screening colonoscopy. If you have a patient that came for a screening and the prep is not perfect and you think you might have missed some very subtle lesion, recognizing that colon cancer and IBD patients often present, or colon dysplasia, often present with very flat polyp, difficult to detect. So you really want that perfect prep, a good slow exam, a thorough exam. So you really have to trust that exam that's being done. And And I think I take that as a baseline in terms of when would be my next test.
And as you pointed out, patients with PSC or primary sclerosing cholangitis are particularly high risk. So the corollary is that I'm always alert to abnormal liver enzymes, especially alkaline phosphatase, and trying to make sure I understand if that is or isn't PSC.
So in terms of skin cancer, patients with inflammatory bowel disease are at increased risk of melanoma. And this is actually independent on whether or not they are on biologic therapy or other immunotherapy. Now, if they are on biologic therapy, that risk of melanoma is further increased. Patients on thiopurine are at high risk of non-melanoma skin cancer. And what's important to recognize is that that risk persists even after you stop thiopurine. So thiopurine create, photosensitivity and DNA damage that persists even after stopping the therapy. So in your patient who has been on thiopurine, if later you transition them to different therapy, just be mindful that this patient still require routine skin cancer screening. So, of course, there are other factors you want to take into account in terms of risk of skin cancer as you're making a recommendation of how often your patient needs to see the dermatologist for a full skin check, including having a fair skin, multiple sunburns, maybe have a job where you're outside most of the time, or if you like the outdoors, which is a good thing, but if you don't use sun protection, that can cause skin damage, and if you have a personal history or family history of skin cancer. So what I do recommend to my patient, all my patients, use sunscreen when you're outdoor, plus it prevents wrinkles. It's really good for everything. So use sunscreen when you're outdoor, or a hat or a cap. And I actually recommend a skin check at the time of diagnosis. And I recommend it every year, and I'm gonna tell you why. Because again, independent of IBD, independent of immunosuppression, there's a risk of skin cancer, and often it is ignored, and we have patients coming in with more advanced melanoma or non-melanoma skin cancer. The other thing is that most of the time when you recommend something to be done yearly, it ends up getting done every 2 years maybe. So I reinforce that with every visit because this is preventable when skin cancer is diagnosed at an early stage, it's curable. So it would be a shame to miss that. And then the other cancer we, like the audience pointed out, our patients are at higher risk of is cervical cancer, mainly in patients receiving thiopurine therapy and in patients who have HPV virus. So this is when I really also rely on my OBGYN in terms of how often we're going to do a pap smear. In patients who have no HPV, they receive HPV vaccine, if they have normal pap smear, 2 normal pap smear, they can go to every 3 years. But patients on thiopurine, especially patients who are not in a monogamous relationship, I do recommend a higher surveillance interval, so every year. And this is, again, we do that in collaboration with the gynecologist.